So Mark Twain, who I love, said, "I'm all for progress. It's change I don't like." And we've all been faced with a bunch of change. Some of the things we just roll our eyes and say, do we really have to incorporate that in our practice? I was that way with electronic medical records. I shared with Karen and Nish last night our meaningless use, I call it, or meaningful use program, and it's just tough to see some of these things happening, but let's talk about the easy ones. So first of all, when it comes to cornea, we all know that presbyopes just want to go back to when they were 20, and they don't really want to deal with other options other than perfect vision at all distances. But this is a patient, 52-year-old, presenting with, I'm losing my glasses, I've got readers everywhere, I go to Walmart and buy 3 new pairs a month, I can't find them, I have to change the glasses, they're not right when I put them on. And so, bottom line is, what do we do about these folks? They don't have cataracts, it's too early. Clear lens extraction is kind of dramatic. This is someone who's 20/20 and J10 up close. And really the perfect candidate for maybe several things. Glasses, the simplest, monovision contacts, multifocals. But what we're here to talk about for just a couple of minutes before we get into the other more in-depth topics are corneal inlays. Now, I've got a long history with these because when I trained at Bascom Palmer in the early 80s, we saw a lot of people from South America who would be referred up. And believe it or not, and part of this was the language barrier, but I had translators and I learned as much Spanish as I could, didn't know what was done to them, but they knew that after this surgery by Dr. Eyecare, they can't see too well. And you'd look and there'd be this opaque central disc in the cornea. And these were people that underwent the first keratomileusis procedures, where a piece of cornea was taken off, frozen, put on a lathe and ground down, and then reinserted in the cornea. And it was pretty barbaric. It obviously wasn't even close to approval in this country. People were watching it. But myopic keratomileusis and hyperopic keratomileusis were first toyed with Eyecare, and there were a lot of patients that truly were human guinea pigs. You go from there to the early Eyecare days, and I was fortunate enough to be part of the PERC study, the prospective evaluation of radial keratotomy. Well, how many still see Eyecare patients with 24 incisions and arcuate cuts and just a mess, and now they need cataract surgery and they're in a world of hurt, and they have cataract surgery and their vision fluctuates tremendously over the first 3 or 4 or 5 months, and you have to tell them, hold on for the ride, don't let anybody exchange the lens because you may be a -3 the first day and a +3 next week, and so don't go letting anybody chase the right implant. But all of these things I consider experimental, but some of them became adopted fairly universally, at least for a short time. And you saw what happened with RK. We don't do it anymore. That may or may not be the case with these corneal inlays. And the first one to be approved was the camera there was all kinds of excitement because it was at ASCRS in San Diego last year, and I was there, and it was approved that Friday, and it was the big buzz. Although a lot of people weren't planning on doing it, they were excited that something new was approved. And it is approved for emmetropes 45 to 60. You can see it here with needing a +1 to +250. And it's really a pinhole effect, a pinhole disc that's inserted through what's called a pocket procedure, and there are only a few lasers approved to make this pocket. We don't currently have access to one. As soon as we get access to one, my corneal surgeon's going to start doing a few of these to just see. A lot of people are dipping their toes in the water. Some have done 6 or 8 or 10, and then they've stopped doing them. Others are full speed ahead. It just depends on risk tolerance and what kind of pioneer or cowboy surgeon you're dealing with. So here's the inlay. We had a very nice presentation at my Omni Center Director group a few months ago by the company, and one of the chief researchers in the company is a female optometrist who's very smart, and so we wanted to be open-minded to it. She's had the inlay, but she had the early one where all the individual pores were the exact same size, and she's shifted a little bit toward hyperopic and is going to need a LASIK touch-up. But I mean, there are some success stories. So let's take a look at it. We actually had the opportunity to insert these into a grape. We actually did optometric grape surgery, and all of the grapes are doing fine, a little bit soggy, but, and it was kind of fun to put these in and pretend to be a surgeon for an hour. 5-micron thin, micro-perforated aperture. You can see the dimensions, 3.5 wide, and the aperture is 1.6 millimeters. And there are 8,400 holes. And the original one, like I say, the holes were all the same size. Now they're different sizes to allow nutrient flow in and out and not cause corneal decompensation. And then it's put into this lamellar pocket. There are others on the horizon. There was a great review of all this in Review of Ophthalmology this past month, if you want to read further, and you'll know as much as I do. The Raindrop is in phase 3, and it's really just a contact lens with no power that alters the curvature of the cornea to get its effect. And then there's the FlexiView micro lens. This one's interesting because if you put it in an early presbyope, you can then later take it out and put in a higher powered one. And this is somewhere in our FDA process, who knows where. So whether or not any of these get approved, the last two is questionable, but they're in the pipeline. And so, you know, I think it's interesting to watch this technology and not poo-poo it. Am I totally excited that this is a good technology and, you know, it'll be done on a large number of people? My guess would be no, but I'm trying to remain open-minded and just watch it and see. And, you know, there are plenty of surgeons in your area, I know, that have, or a handful of really good surgeons that have tried it. So the key is to talk to them and talk to your patients that have had it done, and just keep close watch on it. So because we started a little bit late, I want to jump right into cataract surgery, and this will take us up to a short break, and then we'll carry on. So how many like me are sick of hearing how many baby boomers there are? You know, there's 10 million baby boomers presenting to your office every day. Really? Where are they? I'm one of them, and you know, we know that the boomers have a fair amount of money, a lot of them, that they'd rather spend on themselves than leave to their annoying children that tortured them their whole lives. So there are people with disposable income that are young enough to want to have an active lifestyle, and that plays into all these new cataract options. Where are we with cataract surgery? Well, isn't it interesting that in the old days, people would ask you when you went to send them for cataract surgery, are they going to do it with the laser? And do you remember almost apologetically saying, no, I'm sorry? And they'd look at you like, you loser, you're not going to do that with the laser? Well, why don't you have a surgeon that does it with the laser? And now that we have the laser, but it costs money, they're like, you loser, I'm not paying any extra, I just want the regular. Just fill it up with regular. And so all those years that I tried to dance around that laser question, I even finally came up with, you know, we have something better than laser. We have the ultrasound. And they'd say, oh, really? What's that? And it's really cool. It carves out your lens, and all these shock waves go through your eye and beat the crap out of the cornea, and it's really good. And after I got that pitch down, along comes the laser, and now I have to say laser's better because it doesn't create shock waves in your eye. And so it's been kind of an up and down roller coaster. But we should be the authority on all the things we're going to talk about, and I know many of you are. We should not just turn the information over to the ophthalmologist or leave it in the hands of the patient who can get on a website and figure it out for themselves, because I will tell you firsthand from the referral center point of view that if a patient comes to us and we do topography first off, we'll talk about that, and they have 3 diopters of astigmatism, and I say to the patient, okay, you've got astigmatism, you're a good candidate for the toric, and you don't even get the T out of toric, and they say, I have astigmatism? What's that? Dr. Briggs didn't say anything about that. I'm sure he did, but they don't remember it, or maybe he didn't and just wrote the prescription, and because after all, what are they going to choose not to have the astigmatic correction in their glasses? So, but it makes him look bad. They say, why didn't Dr. Briggs tell me about this? And they start wailing on Dr. Briggs, and I start my little co-management tap dance, I call it, where, well, I'm sure he's mentioned it, but it's not that important until you need cataract surgery, and now it's important to talk about, and he wanted us to go over that with you. It would have been much better if the patient came to us saying, I know I have a lot of astigmatism, he talked to me about the toric lens, and that's what we want to do. Surgeons love that. If you think you're the one deciding for the surgeon, no. Surgeons love that. I love when I get a referral sheet, we have referral pads that doctors are supposed to fill out. Usually it just says, see Dr. Ajamian, cataract evaluation. That was helpful. I mean, is there anything else you want to tell me about this patient you've seen for 30 years? How about they've been in monovision for the last 15 years and they're doing great. Please set the right eye for plano and the left eye for -175. And when I see that, I just type it into the record. I mean, I confirm it with the patient, but say, that's the way you want to do it? Absolutely. So please give your advice, because you know much more about the patient than the ophthalmologist is ever going to know. And they want you to guide those patients. If an ophthalmologist doesn't, find another one. So are you going to do it with the laser? Well, if there's a reason to do it with the laser, and we'll talk about that. When we went to get our laser, and we bought the first one in, and by the way, there's really very little tie-in between the fact that Alcon is a good sponsor and supporter of your association and the fact that I'm talking about Alcon products. It happens to be what we use, so it's really all I know to talk about. There is another laser, the Catalyst, that close friends of mine have, and they think it's fabulous as well. So I'm not pushing one product or another. I don't get paid by Alcon for anything except one meeting I did last year, a key opinion leader meeting, and I went there to learn more about their stuff. And so bottom line is, we use the LensX laser. We had the first one in Atlanta, and my surgeon, who's outstanding, he's about a 4.5, 5-minute surgeon without anything, without laser, without anything fancy. Of course, all these technologies have added time on to the procedure. I said, Lawrence, why do you want the laser? I mean, you're already a great surgeon. He says, because I want to be better. And there are certain cases where this is going to help me to be better. Mature cataracts, corneas with gutata that are predisposed to decompensation. Anybody with under a diopter of astigmatism. So the early days of thinking that the laser was going to take the 3 or 4 cataract surgeon a week that mostly does primary care and make them better, that's totally out the window, because the surgeons that are good with the LensX have to do a lot of it. They have to be meticulous. They have to be obsessed with nomograms and outcomes and pre-op testing. And you can't just play around with the laser be a 20-minute cataract surgeon, and at least in the States there are plenty of those, 20 to 40-minute cataract surgeons, if you can believe it. I mean, what are you doing in there for that long a time? A little exploring and looking at the retina, and I mean, it's crazy. Those are surgeons that aren't going to be able to handle the laser. So this is for the pros. So we got our laser, we got totally criticized by, we have now 3 or 4 look-alike referral centers in Atlanta. These are people that testified against us, but now they're our friends and they want to work with us. And they came out in the newsletters, it's too early to adopt this, it's a gimmick, it's a money maker, it's, you know, there's Omni going at it again. Well, that was in January of 2013. As of last week, there are 15 lasers in Metro Atlanta. So, and every one of those practices that criticized it has one. So people obviously recognize that in certain circumstances, there's a lot of benefits. What does it do? You all know this. It makes the capsulotomy, that's critical. It breaks up or pre-chops up the nucleus so that all you have to do is vacuum it out. You don't have to use that ultrasound. It does do arcuate cuts on those that it's needed on. And probably the least important thing it does is that it makes the primary and secondary incision. And this is the OCT guidance. Has everybody seen plenty of LensX procedures? I'm going to show just a couple of short videos. But I actually, just for the fun of it, got certified to run the laser, short of stepping on the pedal. And I did I had to do 20 cases, 20 patients. And basically the operator stands in front of this screen and the surgeon says, why don't you move go ahead and move the incision location in or out a little bit, that yellow box on the right at about 4 o'clock. Why don't you recenter the treatment area, the yellow. I'm just going to point out some of these things. I'll try to do it on both screens here, but purple is the capsulorhexis. So you'll see a little purple progress bar, and the first thing that's done is the capsulorhexis, and that bar will fill. And when it's totally filled, it means that the capsulorhexis is done. That's purple. This is the anterior capsule. This is the lens. The lens is yellow. The next thing that will happen is the line that you see creating the capsulorhexis will defocus, and you'll see it focus deeper into the lens, and that's the yellow. And so as operators of the laser, we can expand this or narrow it and center it on the lens, and that's surgeon dependent. And there's also a yellow progress bar that looks sort of like this one, but it's solid yellow, that will fill with yellow as that treatment is being done. You'll see that in the video. It pre-plans the wound. It's a 3-stage wound. And then the primary, the arcuate cuts are made first, and then the primary and secondary incisions. So let's we'll look at those videos in a minute. Again, in all fairness, there are 4 systems out there, but in the US at least, there's about 500 LensX and about 150 Catalysts, and a handful of the 2 on the bottom. This is the first one out. Catalyst does not have a fixed bed. You can see that the reason we like the, the reason we like the Alcon is that we just wheel the stretcher in, lay them down, and then the contact lens patient interface docks onto their eye. We undock and then just wheel them into the surgery center. With the OptiMedica, there's a fixed bed, so they have to get out of their pre-op chair, get into the bed, get out of the bed, get back on another chair, and go into the OR. Really, that's the big difference. The incisions, I told you, are planned in a 3-stage way, and that's just happens automatically. And it scores the incision, and sometimes you'll see the surgeon, he goes in with the instrument and just sort of completely opens them. The laser arcuate incisions for astigmatism are precise. They're perfect depth. We know from RK that it was depth dependent, yet it took a long time for people to figure that out. So they do 8 incisions, and if you only got a half diopter of correction, you'd do 8 more, and you'd do 8 more, and they were all at 30%. Well, it's the depth of the incisions that count. And under OCT guidance, this gives the exact correct depth to get the appropriate correction. Versus manual arcuates, which again reminds me of RK, which are really hit or miss. We did them for a while. We charged $300 per eye. It was a limbal relaxing incision or CRI, corneal relaxing incision. Maybe you got a quarter, maybe you got a half, and maybe it lasted, maybe it didn't, because it's depth dependent, and again, it's hard to determine with a knife how deep you are. So these astigmatism cuts are made in the OR under guidance by some of the pre-op tests we'll talk about. And then you can open them later on if you don't get enough effect. And as a matter of fact, my wife had cataract surgery a year ago in one eye, had 3/4 of a diopter of cylinder. The arcuate worked for a while, got her down to about 0.12, and then it slipped to a half, and she wasn't happy with that. So we opened it up in the office, and she's at about a quarter. And this is me opening up a different patient. Would not try it on my wife. What are you doing? So I left that to someone else. But bottom line, you take this little golf club spud kind of instrument and just open up the incision back and forth. And this is another patient that had a half, and after we opened it, it was down to 0, last I heard. So here's a typical patient, 11/11/2014, had 0.62 diopters. You can see the little bow tie. And of course, topography is critical, and I hope you all use it constantly. If a premium lens patient comes back and they're not seeing well, the first thing we get is a topography. They might be dry, and you'll see that. But here's a nice little bow tie, 0.62 on November 11th, and then on December 16th, a month later, 0.12. Very nice result. And the bow tie is gone. That's the kind of result you want. Also, looking at the most important part of the procedure is the capsulotomy, not only the size, but the placement of it. And this gives you a precise capsulotomy, as good as all of our surgeons are at going in, making that little rent with the forceps and tearing a circle. This imprints a circle, and they just go in and pull out that material. Why do we care about capsulotomy size? Because it determines the effective lens position. And also, if you have a good capsulotomy, you'll have less chance of needing a YAG down the road. But you can see that if the lens is a 0.5 millimeter behind the plane where it should be, that 21 diopter lens will only produce 20 diopters of correction, and vice versa if it's too far forward. So you can get induced refractive errors, which defeats the purpose of doing all these procedures and this great surgery if you do a poor capsulorhexis. And then the fragmentation part of it, breaking up the nucleus. There are multiple patterns. Everyone's got their favorite. Before the pattern on the far right of your screen was developed, called the matrix pattern or fragmentation pattern, we would do either a chop or a cylinder pattern, nothing to do with cylinder or astigmatism, but basically circles. You can cut the lens into a pie shape, and you can do a hybrid of the two of those, but we now use exclusively the matrix pattern on the right, and it breaks up the lens at multiple depths into these tiny little cubes. And so why do we care that we're pre-emulsifying or pre-breaking up, cutting up the lens? Because it means less ultrasound energy. And I'll show you when we show a surgery that the CDE, or cumulative dispersed energy, is often 0 in a LensX case. And that's good, again, if they're predisposed to any kind of corneal issue. And we think that the studies will bear out that long-term endothelial cell loss is less and that people will recover faster. So you're going to have to watch really quickly here, but on the bottom right you see the lens is being set. He's asking the operator to drag it down a little bit. I think it was me this day. You use the cursor and hit accept. You hit corneal thickness, it plans the wound. That's fine, the instrument already did all that. It did an OCT as they're laying on the table. We accept that. And there's the capsulorhexis, and ready to go. Laser's ready, step on the pedal. The first thing you'll see is the capsulorhexis being made with those cavitation bubbles. And look at the progress bar, the purple, it's filled, and so the yellow progress bar is happening. Defocuses posteriorly, cutting the lens nucleus into a zillion little cubes, the matrix pattern or fragmentation pattern. We're done with that, and you're going to see very quickly those 3 bars. There's the arcuate at 5 o'clock, and there's the primary incision, and there's the secondary incision, and we're done. And the new software has cut this down to about literally 40 seconds. I want you to also look at, if you would, the angle anatomy here. And we had a very interesting speaker at SECO 2 years ago named Dave Friedman from Wilmer, Johns Hopkins, and he was talking about the fact that if you see a patient with a narrow angle that also has cataracts, forget about the laser PIs as a separate step. They just need cataract surgery, and it will open up their angle as a permanent fix. The chances that these people are going to go into angle closure is very low, but if you're worried about it, don't dilate them and let the surgeon do it on the day of surgery, and that's what we'll sometimes do. But we never do PIs on these people, and why I'm mentioning that is take a look at this angle. This is a narrow angle compared to what we just saw. Look at how crowded that angle is, and it was all related to the cataract. So we did not do a PI, we did femtosecond laser cataract surgery. The patient, I believe, also had astigmatism, but we're going ahead and setting this up, clicking on the wound, we accept that. Everything's been planned out. There's the lens, we're going to drag that down a little bit, and we're ready to go. Here's the capsulorhexis. Purple box being filled in, progress bar on the left. You see the other 3 boxes, so there's going to be 1 arcuate made. There's the yellow progress bar going on up as the lens is cut into little pieces, the nucleus. And then we'll go right into the arcuate cut. And depending on the astigmatism, there's either 1 or 2. And then there's the primary incision, and there's the secondary incision. Now, does this add overall time to the case? Of course it does. We used to do 40 to 45 cataracts in a day, and I insisted that we cut that down to 30 when you have 10 LensX. That's almost like an extra case because you have to bring them into the laser room, get them prepped, get the speculum on the eye, get them set up, get them docked, and it takes time. So we'll do 30 typically with 10 of them being laser. But you can't see the after here, but the angle opened up beautifully on this eye and then the second eye after we did it. So then what do? You wheel them into the OR and you do the surgery. Not that any of you need to see more cataract surgery, but I think it's interesting, given what I said, to pay attention to the upper right-hand screen, that CDE number of 0. And in a typical case with a good surgeon, a moderate cataract would probably be a CDE of 2 or 3 or 4. I've seen it as high as 50 with a rock-hard nucleus, a light perception or count fingers nuclear sclerotic cataract. But just pay attention to that number. He's opening up the wound here. Again, it was scored very nicely by the laser, but you still have to open it. And now he's going in and grabbing that capsule that's already been perforated, and he just pulls it out. So he doesn't have to tear anything. He's just pulling out the perforated capsule. And now he's just poking around. He's going to put a little viscoelastic in. And if you haven't been in to watch your surgeon and don't know what goes on, it's probably a really good idea so that you can tell your patients what to expect. But here we have, and I'm sorry in the format I'm in, I can't really fast forward it, but it won't go too long here. He's giving the eye a squirt so he can have a clear cornea. Do you see the hemorrhage below, the subconjunctival hemorrhage? It's actually above. That's that ring around the limbus from, well, you see it all the way around, from the docking of the contact lens, and you have to warn people about that. So he's going in and he's starting his, I would say phaco, but this is all vacuum. Do you see the VAC number, the bottom blue box? That will go up to 400, 500. The CDE is staying at 0 because he's not stepping on the phaco pedal. This is all just vacuuming out what the laser has chopped up in advance. This is the new Centurion system, which is an incredible advance compared to the old. And you know, he still has some fairly big chunks there, but he's just feeding them in to the vacuum. He's not having to break them up. CDE still 0, vacuum, you know, ranging on up to 500, 600. He's flipping that around, chewing it on up. People will get freaked out, by the way, about that ring around the limbus subconj hemorrhage, so tell them that that's a possibility and it'll go away in 5 or 6 or 10 days. Don't overpromise. You know, when they say, what's the worst thing that could happen with cataract surgery? Tell them they could die. J. Lawton Smith used to do that, and he had a woman with a massive stroke on the table, and she said, thank God I didn't die. So, you know, always give them the worst case scenario. And so you can see that the CDE in this case ended up at 0. He now will take out the cortex for 30 seconds. He'll put in the lens implant, and the case is done. This I threw in at the last minute because it is very interesting. I'd never seen one before. You all have seen these posterior polar cataracts that have been with the patient their whole life, the little white dot on the back of the lens. Well, what is that? It's a remnant of the hyaloid system that never totally resorbed. And it's very difficult to get rid of that if it's bothering the patient and not take the back capsule and break the back capsule with it. So this is a case that he was so excited about, he wanted me to come in and watch it, and I did, and we recorded it. And so this is a really good case, just like a mature cataract or a traumatic cataract, to use the femto, because the femto will do all the work all the way back to that polar cataract so that he can then try to gently tease that plaque off without breaking capsule. So he's putting the Helon in here, and you can't even see the polar cataract now through the matrix pattern of the LensX, but you'll be able to in a minute. Plenty of viscoelastic, which of course can cause high pressure if there's some retained viscoelastic. And I think some of you, if not all of you, have experience with burping the wound if they come in for the 1 day or the 1 week and the pressure is 45 or 50. That's not a patient that needs drops. They just need you to push on the paracentesis and burp the wound. So this was not at all a dense nuclear cataract. As a matter of fact, there was hardly anything there. We were doing surgery to get rid of the polar cataract. So you can see how easily this is all going to come out. And again, the CDE number in the upper right, I'd call your attention to, is remaining at 0 while he's just vacuuming out the nucleus. And once he gets the nucleus out of the way, it will expose the polar cataract. And there you see it there. There is a light reflex there, but you're going to see the dense white blob that, you know, was bothering the patient finally enough to do something about it. So there's the polar cataract. And this is the part that I think is so interesting. And you know, I marvel at all of our modern day surgeons. I'm sure most of you work with one as skilled as mine, but I just, his abilities and his steadiness and coolness under pressure are incredible, and we're glad we're able to work with people like that. So now he's going to strip the cortex, but very, very carefully, because that polar cataract is part of that posterior cortex. And you're going to see that it sort of lifts up a little bit, but if you're not careful, it will lift a hole or a rent in the capsule, and vitreous all of a sudden will be in the anterior chamber. You see, there it goes. He's separated it very nicely, and all of a sudden it's just going to get sucked into the irrigation system, and it's gone. Beautiful, clean case. Okay, so we've got this laser. How do we present it to patients? We don't want to oversell it, but if they have astigmatism and they want to see clearly in the distance, some practices are selling a best distance vision package, some are selling an all vision package. We still haven't quite figured out exactly how we want to end up marketing it, but if they want to see in the distance without glasses clearly and they've got astigmatism, you can talk about the laser and charge for it. If they have other reasons to do it, or if they're getting a Restore or a Symphony or Tecnis multifocal or a toric, we include the laser with it. And we'll just finish this up and then take our little break. So who's a candidate? I've laid it out: Gutata, Fuchs. The mature cataract and the traumatic cataract patients often have scarred anterior capsules, so being able to pre-cut that with the laser is very important. Otherwise, you're using trypan blue, and it's hard to do the capsular excess and visualize it, and it can be a very difficult case. This makes it easier for sure. And then, of course, we've got the what's covered and what isn't, and this discussion, I wish someone would teach me how to do it in a clear, concise way, because I'll say, your insurance will cover the basic surgery, but if you want this, this, or this, that's going to be out of pocket. And, well, how much? $2,300. So my insurance isn't going to cover it. Or, well, I have a supplement, so they'll cover 80% of that $2,300. No, $2,300 out of pocket. We need the cash. Be quiet. I guess that's maybe why I need some counseling on how to. So what's covered and what's not, what you can expect post-op. I mentioned that ring around the limbus. The anterior chamber reaction is usually the same, if not a little bit better, because there's less ultrasound trauma. The astigmatism should be reduced, but because that contact lens docked onto the eye and sucked onto the cornea, there may be a short period of time when the vision is not what they expect it to be. Now, I don't know if, I know a lot of you, most of you have seen tons of post-ops. Have you ever lived with a post-op? Well, that's what happened with me, with my amazing wife, who's asks a million questions about everything. She's an RN. And she woke up the next day after surgery, and I find her sitting at the kitchen table crying. I said, what's the matter? I never should have had it done. My vision's horrible. And I said, just hang on. By 2 o'clock that afternoon, she was 20/15. So living with post-ops, not so much. So this is a new category. It's, very technologically and precision driven. And we're going to talk, and I think this is probably a good time for just a short break. We're going to talk about some of the things that can help make the laser better. I'm going to very quickly go over IOLs, and then we're going to get into some other things related to retina and glaucoma. And again, in fairness, there are 4 systems out there. I only know the one because it's the one we have, not because I'm here to promote it. There are a various number of ways you can make errors along the way, from doing a bad topography to an A-scan to putting in the wrong information into the final planner. That can lead to poor IOL positioning, including the wrong axis. All of these things we're trying to maximize because cataract surgery is no longer, as we all know, well, you're an old person and you're 20/80, and as long as we get you a little bit better by taking that cloudy lens out of the way, you should be happy. No, it's let's get you as close to 20/20, unless there are other things going on in the eye, as we possibly can. And so the Varion is what we use. It's called the digital marker. The reference unit on the left-hand side is where it all starts. We run this in the clinic. We take a picture of the eye. I'll show you that up close. It turns that into a plan. That's then transmitted to the LensX laser and to the digital marker in the microscope, and you'll see why in a second. So this is the image, and what it's doing is really recording scleral blood vessels and iris crypts and locking that in to the instrument so that when the laser takes a picture of the eye, which it does before the procedure starts, it will match that image to the one that we took in the clinic to make sure that first it's the same patient, secondly that if the patient cyclorotates or moves their eye, everything is tracked along with those movements. This is the planner that goes into talking about where the arcuate cuts will be made. This can always be altered by the surgeon if they think it needs to be, but we typically trust it, and the results are spectacular. That initial picture that I showed you, this one here, you can see the axis is locked in. Well, instead of manually marking like many surgeons still do that don't have this, where they take a blue dot and put it at, at 12 and 6 o'clock to align the lens. Well, guess what? That little tiny focal blue dot will become a larger dot by the time they get into surgery, and then where exactly in the dot do you line up the lens? And it's very hit or miss, especially with high astigmatism. And so this particular Varion instrument then puts this virtual reticule in the surgeon's microscope in their view and allows the surgeon to line up the lens with the marks on the lens with that reticule. And you'll see the video here. See the blue dot up top and how that's already sort of spread out? That's where he would have aligned the lens. But look at where the reticule is, the green reticule that comes in and out when the patient moves, it goes out of view, compared to that blue dye mark. It's about 15 degrees off, isn't it? Which with a high-powered lens is going to make a big difference. And so see the three marks that he's got his little instrument over right there? That's not lined up with the reticule yet, is it? So he's going to make sure that that's perfectly aligned with what the Varion marker told us is the correct location. And there you have it. And then it also helps us to align the restore lens and center the restore, or in the case of many of you, the Symphony lens, the Technis. It will help center that lens perfectly because, as you know, that has everything to do with how the near acuity will come out. The other big advance, and we're the first practice in the Southeast to have it, and we got it about 2 months ago, and it's just been unbelievable, is called the Aura. And this is an evolving technology, but it's finally ready for prime time. We've been watching it for 3 or 4 years. There is another one called the Holos. Again, I don't have experience with that instrument, so I'll talk about the Aura, where we've got about 2 to 3 months worth of experience. The system, very cute name, wish I had thought of it, Verify. And what it does is you can see the white unit on the left-hand side of the screen. That's attached to the surgical microscope. So despite all of the pre-op testing that we do that tells us that we need a T4 toric lens to correct 2 diopters or a diopter and a half of astigmatism, the final word is the Aura. It's going to do intraoperative front surface topography, back surface topography, A-scan, refractive calculations, and it's going to tell us if that lens that we had planned for is really the lens we need to use. And It's a wavefront aberrometer. I mean, it's just got everything built into it. It is almost a must for post-refractive, post-LASIK, post-RK patients. Those patients, we tell them, and we charge $500 for it, we tell them in a nicer way than this, you're crazy if you don't pay the $500 for this, because it's going to greatly increase your chances that we're going to put the right lens in. We do it automatically with our toric and restore patients, and guess what? About 3 weeks ago, we had a toric patient, just that same scenario. It said use a T4 lens. We were ready to go. He had the lens in the OR. Aura said do not use a toric lens. Based on all of the calculations, use a standard monofocal lens. He didn't trust it at first, and he's ready to blow it off. I was in there, and he says, do you think I should trust it? I said, you're the one that made me spend $80,000 for it. Trust it. We trusted it. The next day, the patient was plano, 20/20. So there's been about 6 or 8 surprises like that where we trusted Aura, and it worked out beautifully. And this will become commonplace. It really will. Again, especially for post-refractive. But when someone's paying that amount of money for a toric or a restore, this is the final check. We'll skip through this. This is a view of the Holos.
Sorry, Doctor, when during the surgery is the Aura used?
Fantastic. When is it used during the surgery? Right before he's ready to put in the lens implant. So he's taken out the cataract, it does final measurements, and it verifies either what he was planning or it changes it.
What kind of inventory do you have to have in stock then of IOLs?
Great question. What kind of inventory of IOLs? A large one. Very large one. So new technology, it's the future, and people are going to catch on. Very quickly through the IOLs, much of this is routine for all of you. The 2.5 restore, let's go back historically real quick. When the restore first came out, which is that and the Technis are the only ones that we have in the States. We don't have the Symphony, which is a version of the Technis AMO. We had the +4. And so restore patients that were paying $3,000 we're seeing here, but nothing outside of that. They were not happy. So Alcon got the message, they created the +3. Even with the +3, there are people that do a lot of computer work. They say it's fine when I read, but when I go to look at this computer, not so good, I need a supplemental pair of glasses. So the 2.5 came out. The studies in Canada and Europe that led the way looked at putting the 2.5 in the dominant eye. It has fewer rings, and so the distance vision is a little bit better with fewer distortions in the distance. And this model eye, which I don't totally believe, kind of illustrates that. But bottom line is that to put that 2.5 in the dominant eye for distance and relax the intermediate, so that would be the computer eye, and then the +3 in the non-dominant eye, we've done close to 600 patients that way with the mix and match, almost like a mini monovision type of thing, and it's worked out beautifully. I mean, I can't think of one that we had to exchange or where the patient wasn't happy. If all they do is read, which is rare these days, then +3s in both eyes. If all they do is computer and they tell you that they're not doing anything up close, but their whole life is on the computer, arm's length, the +2.5 in both eyes. And distance vision good, and reading and intermediate excellent as well. The Restore Toric, what a story in the States, and then you go right over the border and you all have had this approved for how long? Quite a while? At least 2, 3, 5 years, I think. Every year we are told that it's going to be approved. Last year it was approved, but then there was some labeling issues. Still not available. We have a wait list for this because anyone with over a diopter of astigmatism that also wants that multifocality, guess what? They can't have it. And so we're hoping that, short of sending everybody up to you guys, we don't like that. Those are called metastatic cataracts that metastasize out of our office to someone else's. We are looking forward to this. You all have a lot more experience with this. I talked to Karen and Nish last night about this, and apparently very good experience. The interesting thing with the Technis multifocal that we have is that those rings extend all the way out to the periphery, and you wouldn't think that that would work as well. You would think that there'd be more halos and glare, but my friends that are doing them, and we're not, are very happy with it. But instead of the 2 focal points, it's the Symphony takes that concept further and kind of creates this continuum due to depth of focus, and it appears to be working very, very nicely, and we'll look forward to having that as well in about 30 years. And then the toric, at least on the Alcon side, the toric lenses, the range was extended all the way up to about a 4 diopter effective lens power for astigmatism. And anyone not doing a lot of torics, I mean, we've got advanced surgeons in Atlanta that refuse to do really any premium lenses. We don't believe in them, or they've had a couple bad experiences. But if they're not doing torics, that's just a crime. I mean, to offer that to patients, and then in your chart to write down clearly if they don't want it and they've got 3 diopters of astigmatism, to write down patient denies toric due to money. That's important to have that in there, because if they talk to somebody at church or in the grocery store and, why didn't you get that lens that corrects for astigmatism? I don't know, why didn't I? Dr. Patel didn't tell me about it. Well, you've got it on the chart that you talked about it, and they clearly stated they didn't want it for whatever reason. I've had patients that I've had the talk, I've put it in the record. The next day, I'm doing the 1-day post-op. Oh my gosh, why is everything so blurred? Well, remember that astigmatism lens that we told you would, if you don't get it corrected, it would make things blurred? Yeah, but I didn't know that it was going to be blurred. What the heck part of what I talked about didn't you get? And I look at the record, there it is, extensive discussion with patient, doesn't want it, and you know, there you're protected. So our role in all this, as I mentioned, is critical. It all starts with topography, because without topography, you don't know whether you can even talk about a multifocal lens if they have a lot of astigmatism. You don't know whether you should talk about a toric. Don't do it, please, based on the refraction. That has nothing to do with the cylinder that you're going to try to eliminate. That's corneal cylinder. If they're a -3 with a -3 axis, whatever, that means nothing. That could be lenticular cylinder, and you do a topo, and they've got a 1/4 diopter. So everything starts with topo, and then you advise them from there. Which topographer? Anyone. The Atlas Humphrey is the one that's our bread and butter. But great segue question, because only the Pentacam and the Cassini do back surface, and we're seeing a lot of movement over the last few Academy and Ascaris meetings talking about back surface astigmatism. Now, most patients, if you measure 2 diopters on the front surface, that's what they have, and the back surface is negligible. But take a look at these cases, and we had a Cassini for about 8 months, and if it wasn't so painful for patients, I might think about buying it. See all those lights? It's not a keratoscope with the rings. When you press the button, that thing flashes, it looks like a disco, and the patient's like, oh my gosh. Stay in there, open your eyes, okay. Anybody tired of that? We're not at the dentist's office, just, but it hurts. I mean, so 1 out of 10 Cassinis, we couldn't even capture, it's so bright. But what it does is, if you look at this, and let's see, I'm sorry, it's a little bit out of focus because of our connection here, but see the center, I'm going to call your attention to the center column, and the anterior segment K is 1.25, but the back surface is 0.45. So 1.25 plus 0.45 is going to equal a total, and again, you can't really see it. Let me look at it on the screen. Is a total of about 1.89. So what we were basing everything on was 1.25. It's really almost 2 diopters of cylinder because of back surface. This is getting a lot of attention. Now that's the patient's right eye. What about their left eye? Left eye was 2.41, and the posterior below that was negligible, almost nothing. So the total was 2.57. So what we got on the front surface is what we'll use, but this is where aura also comes in as kind of the final decision maker because it's looking at back surface as well. But for the most part, for your selection purposes, using the atlas or any of the basic topographers is great. Get my good side, please, which is back here. All right, so patients, again, want your advice. I told you they don't want to be surprised. And if a surgeon just makes a couple of grunts or groans, like we still have plenty that are happy to do that and implicate you as, oh, she didn't tell you that you have astigmatism? That's normally the way people do it. And you get a couple of moans and grunts and funny looks like that, and the patient is thinking, what's the matter with my optometrist and why didn't they tell me that? And also getting them ready for the price factor so that they don't hear that for the first time. Always important to select the surgeon based on skill level and not necessarily distance. We have over 500 referring doctors in the Atlanta area. Some of them don't send to us because we're 20 minutes away. And, well, you could go to Omni, you know, there's a lot of traffic on the way there. They're very good. I mean, they're the best, or you could also go to Dr. Malignant right up the street that's testified against us, and, well, is he closer? Yeah, oh yeah, he's right next door. Oh, okay, I'll go to him. But when their relatives need surgery, I get the sheepish call. Do you mind if Dr. Woodard would look at my mother-in-law? Well, that's not a good call. That's not fair. Mother, not mother-in-law. So know the surgeon, be able to go to surgery with them, know their routine, be able to communicate with them, and know that they are going to take your advice when you give it. The post-op care, we talked a lot about that last night at dinner. It was very enlightening. I know a lot of you are involved with post-op care. You don't get paid for it. We barely get paid for it, but we tell our ODs, if you're sending from an hour away, please do the post-op care. I mean, that's goodwill. It's a very short visit. Granted, it can be complicated by drops. I'm going to talk about that in a minute and how we're trying to simplify that. But bottom line is, what's happening in the States is that we're abdicating the post-op care, even in ophthalmology practices that have an OD that I think is the one that should probably be doing it. There are PAs and nurse practitioners doing post-op cataract care. There's now a program at Wills Eye Hospital I recently heard about, an ophthalmic PA program. They're training them to treat glaucoma and to do post-op care. Really? So why aren't we doing that? Now granted, you don't want to do a ton of stuff for nothing. I don't blame you there. But we shouldn't abdicate post-op care. We've worked hard to get the therapeutic privileges to get us to the point where we can handle these things. So why do my ODs call up my marketing rep, they're too scared to call me, and say, you know, we're not going to do any post-op except for the premium lenses where we actually pay them in addition to what the insurance pays them for the regular post-op care. Well, why do they want to give it up? Because the medications are so confusing. And, you know, is it fairly standard here to do like a pre-op NSAID and antibiotic and then add the steroid post-op so they're all on 3 drops? And I think that's become standard of care. So you prescribe a once-a-day Ilevro, or, and again, I'm not sure if the drug names are the same, but a once-a-day NSAID, a twice-a-day steroid, and a 4-time-a-day antibiotic, and then our pharmacies switch them all the time. So they come to you and they don't know what they're on. They say, well, this one's, the blue top is 4 times a day, and the wait, did you bring them? No. And you're sitting there for 10 minutes trying to figure out, no, but I can call my daughter, she's at work, but maybe she'll know, and time is killing you. And it's just a quick post-op vision, pressure, and check the cell and flare and get them out the door. No, now it's 15 minutes. So there's a movement to come up with less drops, and Imprimis, the company that makes the injection that I'm going to talk about, also makes a bottle that's a 3-in-1. This is a compounding pharmacy in Chattanooga that a friend of mine said to his pharmacist friend, can you make up these drops? And I think they'll ship them to you. It's $55 plus shipping. It's a little more, bless you, complicated, because now you're relying on the patient to talk to a pharmacist after the prescription's been called in, and I don't know how that would work here. But let's cut to the chase and say that we've solved that by using 3 less drops. And that makes a total of 0. We started it in January, and it's called dropless therapy. And it's a compounded triamcinolone and moxifloxacin. There is a combination that includes vancomycin, which is $5 more. The trimoxy is $25, the vanc is $30. And here's the problem, again, in the States, because it's not approved, nobody's paying for it. So you can't bill the patient, and you can't charge their insurance, so we have to eat the cost. So the reason surgeons aren't doing it in the United States is, especially if they own their own surgery center, they'd come out of pocket $100,000 if they're doing 3,000 cataracts, and they don't want to do that. So we do. I mean, we didn't, but I convinced our surgery center that we needed to. And it's been the most, of every advance I'm talking to you about, it's been the most amazing thing that's come along in my 30 years. You talk about physically or mentally challenged patients, compliance, understanding, putting the drops in. Talk to anybody about cataract surgery, they say it was fine except for the drops. Again, I lived with a post-op. She had little stickies. This one's twice a day. This one, wait, did I use this one yet? Which one do I need to use? It's a problem. And she was 59 at the time, not 89. So, and then pharmacists switch. We go to do refills for the second eye. They say it's within 30 days. We can't do refills. The time my staff spent, my residents spent explaining, the ODs spent in post-op care, it was ridiculous. So we just got tired of it, and we've gone to this trimoxy injection. Surgery's done, lens implants in. This is not our case. I'll show you ours. And you inject, you create a space with some viscoelastic under the iris, and it's transzonular, and you can see the glob of trimoxy in the eye. I've had a few patients, a few ODs that don't read their newsletter that call the next day and say this patient has a retinal detachment. I say, why do you say that? Well, there's a white thing in the vitreous. So that's the trimoxy. Just hold on to that detachment for another few days and it'll be gone. These are our cases. This is the first one I saw Woodard do. I asked him to videotape it, and so you can see the surgery is done. This is standard surgery. See the CDE of 3.66? That's how you know it's standard surgery. And so he's putting in the Helon to create a space under the iris so he can get through with this cannula, and he injects it transvitreally. Some of it you'll see on the visual axis. Sometimes it goes off to the side and you won't see anything. So of course we want to warn these patients that they're going to see floaters, clouds, halos, dark spots for the first day or two. As long as you clearly warn them and put it in writing, they're fine. They're absolutely fine with it. Here's another case that he did very recently. This was a non-laser case. Look at the CDE of 0.16. I mean, he barely had to use any phaco on this one. Oh, actually, this was a laser case, wasn't it? Because see the ring around the limbus? My mistake. So that's why the CDE was so low. He's injecting the trimoxy. See the helon coming out of the eye because something's going in, something has to come out. You saw a little bit of it peripherally, but the visual axis is clear. This is a patient that probably will not be seeing too many halos or floaters. Let me tell you about the post-ops because I see them every day. The 1 day, they're very quiet. They're quieter than with drops. The 1 week and the 1 month are about the same. There's about a 10% rebound. So they'll have inflammation just like the people on drops that stopped using their steroid. And then you just give them a rescue drop of steroid like Durezol twice a day or Pred 4 times a day, and they're fine. You'll read a lot of nonsense about endophthalmitis and retinal detachment, and we did 100 cases and then we stopped. Read the literature, and if you want me to send you a list that I just sent to our ODs in a newsletter, I'm happy to. But this is going to be coming around worldwide because it's so much more convenient. Patients are thrilled. Had a story of an OD who sent a case. The patient had a pulmonary embolism the day after cataract surgery and was in the hospital dealing with all that. Not one time did they have to think about putting eye drops in. It was all taken care of with trimoxy. Okay, I'm way behind on time. So are you all co-managing eye stints a bunch, or a lot of eye stints being done up here? Some?
Being done, not a lot.
Okay, so it's really taken off in the States. You know that it's the smallest implant, if we go back here, implanted in the human body. It's titanium, but it doesn't set off metal detectors, so you don't have to tell them to worry about that. And our insurance system pays for one of them, although the European study said that it's better to have 2. Their $900 is the material cost, so we're not going to put in 2 just because the study said so. But ongoing studies that I'll show you are actually promoting the use of more than one, but one is working just fine. So there's a learning curve. This surgeon, our surgeon, Lawrence Woodard, has the gonioprism on the eye. He's taking the sharp end of that snorkel and moving it tangentially along the trabecular mesh until it stops. He releases the little inserter that's like a little prong, and then you're going to see the open end of the snorkel that's going to drain fluid directly into the trabecular mesh. It's heparin coated so it doesn't clog. And the worst thing that can happen with these is that it doesn't work. We haven't seen any complications. And he just taps it in there, makes sure it's set, and everything's fine. Next case, a little bit clearer. He goes in from right to left this time, along the collector channels in the pigmented trabecular mesh is his guide. He slides it along and releases the inserter. This is done after cataract surgery, by the way. Again, the FDA has only approved it to be done with cataract surgery for some bizarre reason. So you can't do it on pseudophakics or aphakics. You have to do it at the time of cataract surgery. And then this next case has a little bit of a hemorrhage associated with it. No big deal. They'll have a microhyphema for a few days. Pierces the trabeculum, slides it over, releases it. You can actually start seeing the blood actually going into the little eye stent. So that's the procedure. And let's give you just a classic case of a 64-year-old. He's the brother-in-law of a close friend of mine, referring doctor on Lumigan. Hardly using it, doesn't want to pay for it and doesn't want to use it, so he's using it once a week instead of every night. And what happens is that his pressure goes up to 22 with moderate cupping. We do the eye stent. He's 16 day 1. He's 14 week 1 and 13 at 1 month. We stopped the Lumigan and his pressure has remained in the low teens. That's impressive. And that's an average case. from high teens to low teens. If they're on 3 drops like Lumigan and Combigan, we stop the 2-in-1 bottle, and usually with 1 drop in the eye stent, they're at their target pressure. It's very, very impressive. The MIG study group is studying people in, of all places, my homeland of Armenia. And why are they picking on my people? I don't know. I got to get over there and see. But they're putting in eye stents in pseudo-fakes and phakic patients. They're putting in 1, 2, and 3. Some people say that just taking out the cataract lowers the pressure a few millimeters, so the eye stent studies are meaningless. This blows that away because after washout, look at the pressure, 25, 25, and 24. These are eye stents without cataract surgery, just eye stent alone. Look at the 1, 2, and 3 data on the bottom line. With 1 eye stent, it went from 25 to 15.6. 2 eye stents, 25 to 13.9, and 3, 24.9 to 12.3. That's pretty impressive stuff. And you're going to see a lot of these. You're going to see new devices in the future. You're going to see this eye stent inject like a bullet that goes straight in that will be easier to use. I mean, I've had several surgeons, including one on my staff, that just can't figure out how to do the eye stent. And so we told her to just quit doing it and send it to the other 2. They're going to put in 1, 2, 3. There's a bunch of different designs, suprachoroidal eye stents, etc.
Will this diminish the SLT?
Yeah, to me, this is in place of an SLT. Great question, because SLT I don't think works worth a dang in a lot of cases. So you could do an SLT, and if it doesn't work and they need cataract surgery, at least until we get beyond that combination cataract surgery, and then do the eye stent. But we just go right to eye stent. We forget about the SLT, and it's worked beautifully.
And the patients that have glaucoma, and they would just get cataract surgery?
They have to have minimal to moderate glaucoma and have to need cataract surgery.
But if they had minimal, and then did just regular cataract surgery, their pressures could actually go down post-cataract.
Correct. If they have minimal glaucoma, their pressure's 20, and they just have cataract surgery, maybe the pressure will be 18. But who's to say that the glaucoma isn't going to progress, or that they're going to not have the ability to use drops in the future, or that they don't want to get off drops altogether. So there's a lot of reasons to do this. Okay, who's in charge? Dr. Patel, you are. Can I go 5 minutes over? Okay, because we started a little bit late. So I want to show you 2 other things, please, in 5 minutes. One is related to retina. We know that it's okay that your retinal specialists, because they're doing it all over the world, are injecting everybody for everything. It's just the way it's been. I'd like to be a retinal specialist now. You don't have to do surgery, and you make twice as much money as you used to, just doing in-office stuff. Although it's very laborious, and the future is that some drops need to be designed, or drug delivery systems, to get this stuff in without sticking needles in people's eyes. But drugs are being used, anti-VEGF, for just about everything, including vitreous hemorrhages. I mean, it's crazy. Here are the current injectables, from Jetrea for VMT to Eylea, Lucentis, and Avastin, which all have different prices and different indications, to steroid treatments with long-term implants. These are all about the same, except Eylea works a little bit better. So if you're going to be doing surgery, our surgeon avoids Eylea because it almost creates a retina that is very fragile and crispy and will sort of not react well to a vitrectomy and retinal surgery. Ozurdex lasts anywhere from 2 to 6 months, but typically 3. It's a steroid implant, and here's one of them in the eye. We've done a couple dozen of these. And then we've done 2 Illuvians for diabetic macular edema, and this lasts 3 years, which is a problem if the pressure goes up. Then you've got a 3-year nightmare with pressure, but so far we've had good luck with the 2 that we've done. So you do a loading dose, meaning you're going to give them an injection, and 3 to 4 weeks later, you're going to give them another injection, then you're going to try to start spacing them out depending on their OCT and their symptoms and their vision. And I wanted to show you, for those of you that haven't seen an injection or two, and honestly, as big a retinal practice as we have until I videoed this, I hadn't seen one. So a little betadine, this is a bilateral procedure, and there's Dr. Eyecare, our retinal specialist. And he's just going to go in with the little needle and twist and shout, topical anesthesia. And then he's going to push the drug in, little cotton swab, there'll be a little bit of regurgitation, and that eye's done. Takes the speculum off. Really, patients don't complain much. If they do, we don't listen. Speculum on this eye. I think this is another nice close-up that I thought might be enjoyable to look at. Little betadine. And you know, we talked last night, I mean, some surgeons are doing, 40, 50, 80 of these a day. It's just crazy. And there it is, in, drug inserted, and out. We'll see you in 4 weeks, and you can have this fun all over again. Okay. Finally, what's new? What's the future of glaucoma? And I hope this will end with a good takeaway. Fast forward to this year's CICO, Dr. Donald Hood, he's a PhD at Columbia, has done a lot of work on this. I first heard him at the Optometric Glaucoma Society, and I'm going to cut right to the chase and tell you that through a long, wonderful lecture, he convinced all of us that the OCT that we're all using pretty routinely is really amazing technology. I mean, it's better resolution than an MRI, and it's pretty much the same resolution as killing someone and chopping their eye up and looking at it under a slide. And so we can stop doing that now, if any of you are still doing that. I know you want to kill some people, but so you get this amazing cross-sectional, anatomical, histological view of the eye. What we know is that the nerve fiber layer is affected in glaucoma, but how do you measure it? And so he's done a lot of work on the nature of macular damage in glaucoma as revealed by OCT. And what he did is he took 156 eyes with suspicious-looking discs where they had a normal 24-2. Does everybody like me do 24-2? Yes? Bottom line is he started doing 10-2s. And he also started doing macular OCTs. And he'd find a little bit of damage, but the 24-2 was still normal, and I've got that case, sorry, right here somewhere. Oops, meant to take all those out. And really the bottom line is that the 24-2 poorly samples the points that you want to sample in the macula. And so it fails. And look at the top slide, normal 24-2. You do a 10-2, the patient has a superior arcuate defect. So the take-home here, for those of you with at least a Humphrey, doesn't matter, Octopus I think does the same thing. If you have an early glaucoma patient, we've been taught do a 10-2 for advanced end-stage glaucoma to magnify everything. No. Do it on the patients you suspect have early glaucoma rather than a 24-2, and then alternate them and see what happens. Try it. We've started doing it. It's remarkable. We've had some results like this in the few months that we've been doing it. So we can talk more about that this afternoon, where I think I'm talking about glaucoma again. But early glaucomatous damage of the macula is common, and it can be missed with the 24-2, so think about the 10-2s. I hope this has been useful. Thank you so much for your attention.